Hey, Dr. Labani. Just wanted to go over this Invisalign case with you. Uh, Very standard Bolton case. What do we mean by Bolton? When you have class 1 molars, class 1 canines, the anterior teeth are relatively coupled. Um, Class 1 molar on the left side, class 2 canines on, partially class 2 canine on the left side. But the anterior teeth are coupled, but you have lower crowding, but the upper teeth are more or less coming into contact. You have what's called the Bolton discrepancy. Essentially, what that means is the teeth are coming together normally. The skeletal relationship is good. It's just the tooth widths of one arch are too wide compared to a standard model. There's a very easy way to find this. So if you go over to B, Bolton analysis, you can see here that there's a mandibular excess of tooth width on the lower 3 to 3, that's number 22 through 27, of 1.5 millimeters. Basically, that means in order to maintain class 1 occlusion of the molars and the canines, have the anterior teeth couple normally, you need to remove 1.5 millimeters worth of tooth structure. That's the conventional model of Invisalign and most general dentists and orthodontists' ways of solving these kinds of problems. But like we've talked about, we don't like retraction. When you do IPR, in this case it's lower mandibular excess, you would need to do IPR, interproximal reduction of the lower teeth, primarily the lower anterior teeth, in order to straighten these so that they don't interfere with the upper teeth, because again, you're already coupled. So either you spread the upper teeth out to create space so that you can get these in place, or you reduce tooth structure down here in order to get them aligned. This would be a retractive method. I'm going to make the argument that we should always stay away from retraction because that inhibits the palatal vault, or the size of the garage for the tongue. Instead, what I'd like you to program is to tell the lab technician, the Invisalign technician here, to remove all lower IPR. And I actually don't think any was programmed here. Yeah, it looks like they already did what I was going to propose, that they do restorative space on the upper instead of IPR on the lower. Now, you'll find when we start planning these cases that we're going to take into account the patient's airway, potential airway issues, as a guide whether or not we can do this, or whether or not we should do IPR or not. I think the more that we study airway, the more we're just going to say, let's just not do any retraction for anybody, because that puts them at higher risk. They may not be an airway patient, but we put them at higher risk for becoming an airway patient. The problem is, when you straighten teeth and you create restorative space, you then have to tell the patient, on top of your $6,000 for Invisalign, you need to do a composite or porcelain veneer here. This is a pretty straightforward case. Many cases don't lend themselves to being this straightforward. So you can see where IPR is an easy solution, although I'll make the case that doing IPR well is very hard. It's very easy to create ditching in the teeth that can cause a higher risk for caries long term. But that's a topic for another day. Here, it's a pretty easy decision. Just expand everything, get everything aligned, create some restorative space, and then slap some composite in here and call it a day. I think the patient would be more than happy. If they want a really good aesthetic upgrade, you could veneer either just the laterals or the front 4 or front 6. This looks a little bit trapped to me. I would ask the lab technician to procline the axial inclination of the front upper 4, so the upper 2 to 2, by another 10 degrees, creating a millimeter overjet. So create some space here. That will increase the restorative space needed here, but that's going to remove the potential for entrapment that we're trying so hard to fight in our patients that need full mouth rehabs. We know what entrapment can do to the nathologic system, so we don't want to create a problem that's not already there. When you do that, this space might get a little bit bigger, so I would tell the lab technician to add the additional arch length that is created as those teeth are proclined to the distal of the canine and between the upper 1 and 2. So essentially there would be equal spacing between the upper 1 and 2, upper 2 and 3, and upper 3 to 4. That will help spread out the restorative space needed to help solve this Bolton discrepancy. Obviously this tooth here, we don't like where it is gingerly. I would maybe ask the technician to intrude that tooth, telling the patient that when you're done, this tooth will be restored back to its ideal location. This tooth has obviously worn considerably. It's gone through compensatory eruption in an extrusive manner, giving the CEJ a much more superior position in relation to the adjacent teeth. Small thing, but if you're going to fix this guy up, it's something you might want to consider. Intruding lower anterior teeth like this, there's something called relative intrusion. When you go to straighten these teeth, they are going to tip. It would be wonderful if we could say every time we move a tooth according to the plan that we get 100% bodily movement in the expected direction compared to the computer model. The reality is we're going to get some tipping here. When you get tipping, the teeth will, in essence, look like they've dropped down or intruded. That's not actual intrusion, that's relative intrusion. If we look from the side, what does it look like? Well, as you straighten the teeth, they're naturally going to intrude. Now, this computer model is saying they are going to intrude. In reality, you're actually going to have less apical migration of the tooth, and it will be more tipping around the center of rotation of the tooth versus the center of rotation progressing apically. If you want to have actual intrusion, what I would do, well, first ask yourself, do you need it? Yes, he's got a deep bite, so I would try to intrude these teeth about 1 millimeter past the line that connects the two canines. It's going to look like a lot of intrusion. You're most likely going to have a significant open bite, but you want to over-program or over-prescribe the amount of actual intrusion you're going to get. How are you going to do this? Let me just quickly show you. So, new modification. Here's the original. Let's go to so I'm selecting all the teeth by holding down shift, and then I'm going to do something like this. So here I'm intruding the canines, maybe 50%, and then the rest of it with the lower 2 to 2, something like this, and then I might do this. Alright, looks crazy, but again, what the computer thinks the body's going to do and what's actually going to happen are two different things. So I like that much better. I would tell the patient that we want to level his curvus, maybe not use those words, but level his occlusal plane, and this is going to take more trays than it would if he went to another dentist and simply wanted to straighten his teeth. We are functional dentists, we're not aesthetic dentists. I always try to paint that picture to patients saying the aesthetics is in the eye of the beholder, meaning the patient. We will make things look as beautiful as they want, but at the end of the day, we want things to last for the patient. We want things to be functional. We want things to work better. That's the treatment goal here. It's good because in the age of direct-to-consumer models such as Candid and Smile Direct Club, we want to make sure that we're getting the point across that what we're doing is different than other practitioners or other treatment modalities. If the patient doesn't want to do this, you say, sure, we can straighten things out for you. You're going to be missing a lot of the functional improvements that you could get. That would be a different price point. We can do Invisalign Express for that, but I really don't think I would even propose that to this patient. There's a lot you can help this guy with. To help counteract the intrusive force here, for every action there's an equal and opposite reaction. When you get an intrusive force, there's an extrusive force somewhere else. Well, that extrusive force is posteriorly. So that extrusive force is up. Trays are, the height of contour of trays, how can I say this? You need a button on posterior teeth in order to counteract the intrusive force in the anterior. So this one button here is great, but I would add 2 horizontal attachments to these 2 teeth here. So go to features and then take an attachment like so. The higher up on the tooth you place the attachment, the better. You really don't need 5mm attachments. 4s do very well for most of what we do. And then you bevel this like so. Just like that. Alright. What that will do, there's a supporting force of the tray that will allow the tray to stay anchored on this tooth as the tray is exerting force down in the anterior. Reciprocal retention in removable prosthodontics is a analogy. Alright, so you're going to do the same over here. I would change this button. I don't like rectangular attachments. If you think about it, the actual surface contact between a tray and a button is much less with a rectangular attachment as a beveled attachment. Alright. At some point, Invisalign is going to come around and understand that. And you don't need much. So make these a little bit smaller. Kind of like that. And as far superior as you can. What do I mean by that? You want to place the buttons as high as you can. The trays are stronger towards the occlusal surfaces of the trays, as opposed to the weaker areas down at the cervical part of the trays. The higher up you can go towards the occlusal surface, the better the interaction is between the tray and the button. Obviously, you have to take into account occlusion, so just make sure that the button isn't interfering with occlusion, so when the patient's chewing without the trays in place, they're not banging on them. Sometimes you have to get pretty creative on where to place it according to that. So I would do something like that. I would expand his arches, upright these posterior teeth. Again, these are advanced concepts for what would be surmised as a pretty straightforward case. I just feel like this guy's young and ready to benefit from a pretty comprehensive outcome. You know, he's pretty imbalanced. He's got some orthopedic instability in the system, so I wouldn't be surprised if this drastically improves his life. He's already got recession for a young guy. You know, we could talk about the clefting of number 8. That's not normal. That's another sign of entrapment, chipping of anterior teeth. Cases like this, I always like to tell the patient this is age inappropriate wear or age inappropriate symptoms or signs to drive the point home that this is only going to get worse with time. And there'll come a point in his life when he has much less in the way of options. So maybe throw in some free whitening for the guy and you'd be good to go. All right, hope this helps, and we will talk to you soon. Take care.